You're listening to Medscape's In Discussion series on respiratory syncytial virus in adults, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Forrest Arnold. Dr. Arnold is the chief of the University of Louisville Division of Infectious Diseases and director of the Center of Excellence for Research in Infectious Diseases. He also acts as the co-editor-in-chief for the Journal of Respiratory Infections and program director for the Clinical Fellowship in Infectious Diseases. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, my name is Dr. Forrest Arnold. Welcome to Season 2 of the Medscape In Discussion podcast series on RSV in adults. Today we'll discuss risk factors and complications. I will be interviewing our guest today, Dr. Edward Walsh, Professor of Medicine and Infectious Diseases at the University of Rochester. Welcome to Medscape In Discussion podcast.
Well, thanks for having me. This is an interesting topic.
Yes, Dr. Walsh, you have had a lot of experience with RSV, both clinical and research. We will emphasize the clinical today, understanding that you have been involved with benchside research addressing the description of the RSV viral protein, genetics, strain differentiation, and immunology. On the other hand, you've also taken care of pediatrics as well as adults. What encompasses your day-to-day work today?
Well, most recently, it's been involving primarily the adult population and studying the new vaccines that have come along. There have been multiple trials over the last 4 years that have resulted in now the licensure of vaccines for adults for RSV.
And we will get to vaccines, but first of all, RSV has been up and down since COVID. Where do we stand today with the incidence of RSV? Is there a curve emerging that allows us to predict how bad a year it will be?
Well, it is difficult to predict year to year since the pandemic occurred. Prior to the pandemic, and I think as a sort of a baseline that you can look at RSV activity across the U.S., would be fairly predictable that each fall, starting in the south usually around September, and then moving towards the north as the season went on, and then arriving in Rochester usually right around Thanksgiving, and then the virus would hang around really until the spring, around April. And this was very predictable. You could set your clock to it almost. The severity of the outbreaks each winter could vary substantially, anywhere from 50 to 100% of the usual. But then when the pandemic came along, the virus disappeared, completely disappeared. For a good 18 months, we missed an entire winter. And then the virus returned when the non-pharmaceutical interventions like social distancing and masking and school closures, et cetera, as they let up in the summer of 2021, quite uniquely, the RSV kind of roared back, especially in the pediatric population, not so much in the adult population because they continued to be a little wary of being around crowds and so forth. And so we had an unusual season of a lot of pediatric disease. The hospitals filled up in the summer. And then by early fall, the virus had gone away again. It sort of ran its usual 3 to 4 month period. Last year, the second year after the pandemic, the virus started up probably late August, and it was gone by January. So again, different. But this year, it looks like we're back to the usual pattern. And so what we've seen locally is RSV coming in fairly strongly now in November and into December. And so I'm expecting we'll see it go on through the spring and really reflecting the pre-pandemic situation.
What are the most significant risk factors and comorbidities for suffering significant morbidity and mortality from RSV?
Well, just like in pediatrics, the adult population with underlying medical conditions, primarily cardiovascular and pulmonary, but also diabetes and chronic renal disease, especially dialysis and immunosuppression. These are probably the major risk factors for more severe disease, with one caveat thrown in, and that is the older you are, the more likely you are to have more severe disease. And if you look at the incidence of hospitalization and the prevalence of hospitalization, it increases dramatically after about age 75. It starts to go up at age 60, but it really takes off at around age 75. And this is not too surprising in a sense, because these are the people who start to collect these risk factors of cardiopulmonary disease, the long-term effects of diabetes, renal insufficiency, etc. And then immunosuppression at any age would be a risk factor. And in fact, if you look at the hospitalized groups, you'll see more immunosuppression in younger people, for instance, than you would in the older population in terms of trying to define a risk factor. But in the older populations, it's a lot of COPD, a lot of congestive heart failure.
Are healthcare workers at increased risk for RSV?
Well, they're certainly at some increased risk of acquiring it for a couple of reasons. One, many of our healthcare workers are young, especially the frontline individuals. They have families at home, and they can often acquire RSV from their young children at home. Within the hospital, there's always a risk of nosocomial transmission, and this is something that probably under-recognized by many individuals. We think of flu, we certainly think of COVID as a nosocomial transmissible disease, but it's long been known that RSV is also transmitted on a nosocomial basis, and it can go both ways. So you can go from a patient to a healthcare worker, although I suspect more commonly it's from a healthcare worker to a patient who's hospitalized. The mode of transmission is a little different from COVID and flu in that aerosolization is much less of an issue. It's more of the hands-on kind of care that frontline staff will often provide, and it's the touching and the actual hands-on acquisition of the virus on your hands and then transmission to your respiratory tree by auto-inoculation that tends to be the mode of transmission. The healthcare workers generally won't get very sick because they're generally a relatively young group of individuals who tend to have fewer risk factors and so forth. But I might point out that asthmatics at any age who acquire RSV infection can have quite significant disease, not necessarily putting them in the hospital, but they can really trigger a bad asthma attack.
And you mentioned healthcare worker to patient. That would be a healthcare acquired infection, which is dangerous. How terrible would it be to come into the hospital for a heart attack and then you get RSV while you're there and end up on a ventilator? Meanwhile, you've recovered from your MI and now you have respiratory failure.
Yes, and unfortunately, what you see in nosocomial transmission situations is, when you look at who's in the hospital to start with, today, with our very crowded hospitals, you have to be pretty sick to get into the hospital. And this would be true on the medical and surgical services. And so they're very vulnerable to viral infection. And so acquisition of RSV nosocomial for many of these patients, as you just described, somebody with an MI, for instance, this can be quite devastating and something that needs attention to prevent infection.
And as an infection doctor, I know you share with me that healthcare workers need to be diligent about hand hygiene and then just not coming to work if they're sick.
Well, that's a message that we constantly are trying to get across and convey to our healthcare workers, that it's not good to work when you're sick. This becomes very problematic. Many hospitals, if not virtually all, are short-staffed at this stage, post-pandemic, having lost a lot of healthcare workers. And it's very tempting to come to work when you're having a cold, which is what may be the manifestation. You may have a very slight runny nose, no fever, not much of a cough, and your tendency might be to come to work. But you have to recognize that you could be transmitting this virus or any other virus. And I think hand hygiene is critically important in preventing transmission. Wearing a mask is helpful. And as I mentioned, it's sort of that hands-on contact that's important. In the home, with children, for instance, as we all hug our children, even when they have colds, that's the easiest way to transmit it. You've got very close contact. So in the hospital, wearing a gown would be helpful as well in preventing transmission. So if you have a patient who has RSV, who is hospitalized, and that certainly does happen quite a bit, you're wearing a gown, wearing gloves, and a mask will help prevent you from acquiring the infection from them, and then subsequently transferring it to another patient.
Right. So you've outlined what preventive measures can be taken for healthcare workers and what preventive measures can be taken for different age groups of patients.
Well, the same issues would be involved. I think that careful hand washing when you are around others, especially if they have a cold or have any respiratory symptoms such as a cough, keeping your distance. I don't think that there's great risk of sitting 6 to 8 feet across the room from an adult who has RSV is likely to infect you. I think the risk is low, but you need to be cautious. And I think hand washing is a great way to prevent transmission. And then, of course, we have vaccines now that for specific groups, especially the older adults and those with high-risk conditions, can be what appear to be relatively effective means of preventing infection and certainly preventing a serious disease.
Let's shift to vaccines for a moment and talk about that. But first, I'm going to summarize that it sounds like we're going to have a normal pattern of an epidemic winter for RSV, which is always severe. The major risk factors are heart, lung, kidney, diabetes, immunosuppression, and age. And healthcare workers, as well as others in the home, need to be diligent about careful hand washing, keeping distance, and all of us need to stay away from others and not work sick. So now let's talk about vaccines. Where would you like to start?
It is a big subject, and it goes back about 50 years. So the virus was first identified in 1957, and the very earliest vaccine trials, at least in children, were begun in 1960s. But for the adult population, which is what we're talking about today, the serious approaches to addressing this in a vaccine really began around 1990 or so. So we're talking about a 30-year history. It's known that the fusion protein of RSV, it's one of the surface molecules on the virion, on the envelope of the virion, is key to transmission and infectivity of the virus, so that the fusion protein has been known to be a key target as a subunit vaccine. And for years, we were looking at this as a potential vaccine, as a subunit vaccine. And the studies done in the 90s and 2000 through around 2010 with the fusion protein were suggestive that we were moving in the right direction, but the vaccines were just not good enough, giving us maybe 40% protection, but not good enough. And it really was in the middle of the 2000 teens, that around 2013, 14, and 15, that the key aspects of the fusion protein were identified by workers at the NIH. And that is getting the structure of the protein correct to induce a very high level of neutralizing antibody after immunization with this. And this very then rapidly translated to multiple pharmaceutical companies developing vaccines based on the key structural aspects of the fusion protein. And beginning about 4 years ago, multiple clinical trials from 4 different vaccine companies went through their phase 1 and 2 trials and then on to phase 3 trials for 3 of these vaccines. And as we'll talk about, they've been very successful.
So the Vaccine Adverse Event Reporting System, abbreviated VAERS, is the National Vaccine Safety Monitoring System that accepts reports of adverse events after vaccination. Has that reported anything about the RSV vaccines yet? Because that is the entity that reported events for the COVID vaccine, but we haven't seen RSV adverse events in the news.
So during the clinical trials, there were some adverse events. They were the kinds of events, these what are known as neuroinflammatory events, Guillain-Barré syndrome, for instance, and acute disseminated encephalomyelitis. These are very uncommon events, but when you do large studies, you may occasionally see a case or two. Because of that, of course, the FDA has the VAERS system to follow and look for any adverse event that might occur. Many of us probably remember that was how they picked up pericarditis as an issue with the COVID vaccines. We saw none of that during the clinical trials, and yet we started to see it after the vaccines were released and given to millions. Thus far, I've not seen any issues with any problems so far. In the U.S., about 15% of the population that would be eligible for this vaccine have, in fact, received their RSV vaccine. that is people over age 60, and many of whom have high-risk conditions. And we've not, at this point, been notified that there are problems.
I think people want to know from physicians who know about RSV and don't have conflicts of interest, is the vaccine safe? And if I qualify, should I get it? And I could share my impression, but people are listening to hear your impression. So what do you think?
I think that's a very good point. A couple of issues about the vaccine that I think are important. One is obviously safety. That's always prime on people's thought process. But the second is that we don't know how long this vaccine is good for. We know that it lasts 2 years. What we don't know at this point is how often will we give it. Now, unlike flu, RSV strains don't change much from year to year. So it may be a vaccine that is not needed that frequently. And there's always the potential that we may only need it every 5 years or something along those lines. Like any vaccine, it may be more effective in the first few years that it's given. So taking all that into account, and the advice of the ACIP to the CDC and the advice that was given was that each individual patient should have their decision about this vaccine made between them and their doctor. This is known as shared decision making, which is somewhat difficult because the primary care physician needs to take each patient, and each patient needs to take their own situation and say, well, what are my risks? And I think if you're a 62-year-old person and you're in excellent health and you're either running every day or riding your bike every day or swimming every day and are in very, very good physical shape, you may get RSV, but you're not going to end up in the hospital and you're not going to end up dying, certainly. But as you get older and you're 75 or up, and if you have underlying lung disease, that's a person I would definitely recommend the vaccine for. How often they're going to need to get it is not known.
To date, it sounds like the RSV vaccine appears safe, but it is a vaccine that should last longer than your yearly influenza vaccine. So we will get more data as time goes along. The largest impact in a patient is probably going to be in that first vaccine that a patient receives. And so we'll have more information as the years pass by. Today, we've talked with Dr. Edward Walsh about an overview of RSV in adults. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on RSV in adults. This is Dr. Forrest Arnold for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Respiratory Syncytial Virus in Adults podcast series with our host, Dr. Forrest Arnold. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on respiratory syncytial virus in adults.